previous one either. This afternoon, though, you'll find that it was worth your time staying. We have a very interesting program lineup. Like I said, community practice is near and dear to us as pharmacists. This afternoon, we'll be looking at re-engineering community pharmacy practice. I don't want to take over the work of the MC, the moderator, in introducing the program, but as the chairperson, I wanted to come here first. I wanted to visit. I know this would be the largest session in the afternoon, to welcome you and to encourage all of us to be part of this session. We know that some of the colleagues here from the CPPA session were not able to finish or do their CPD. So what we are going to do is that we'll go through our track 2, our track 1 session. We'll take our presentations on how to re-engineer community pharmacy practice. We'll take our abstract presentation, 10 minutes each. Our colleagues have done research, some of which is on community pharmacy, and their research can help us to inform how we practice in the community. They'll present their results to you. And then when we finish that, we'll give our honorable senior Toski the opportunity to quickly take us through the CPD. So you are covered. You are covered for your points, both here and then the one that you missed in the morning. So just let's all relax and take part in the afternoon session. So with that, I'd like to invite our MC. Our MC. Please, MC, you said people should come forward. You two come forward.
All right. Thank you very much. Let's do it better for our chairperson. Like she espoused, she has already said all that we are here to do. I don't want to mince words. I want us to leave here early. Already, most of us are tired. So I want us to start now. So anyone touched by the Spirit to take us through, irrespective of your religion, prayer. You have to say a prayer before. All right.
Okay. Shall we bow down our heads and pray? Our Heavenly Father, we thank you for this afternoon. We are so grateful to you for bringing us together once again. We commit the beginning of this meeting into your hands. We pray committing the facilitators and everyone here into your hands, to God. We pray for understanding, insight, and foresight. And may you bring us to an expected end. In Jesus' name we pray. Amen.
Thank you very much, Reverend Dr. Ireland, the only man with a country's name. It doesn't happen often. All right. Let's take this opportunity. I think our chairperson has taken us through the reason why we are here, the rationale for our meeting here. So there's no need to go back again. All right. All right. We will take this opportunity to introduce the chairperson. In any meeting, we need someone to chair the meeting or to spearhead the affairs of the meeting. We have to introduce the chairperson. The chairperson is in the person of so we should do the others. Okay. All right. All right. Thank you very much. To me, to moderate this particular session is Paul Jan. My name is Paul Jan, and I will be.
Hi, good afternoon, everyone. My name is Beatrix Ewa, and I'll be moderating today's session. Thank you.
Thank you very much. Do it better for us. All right. Let me take the opportunity to announce the presence of certain personalities. Though the chairperson is yet to come. We have in our midst Mr. Thomas Boatina, our former PSGH president. And we have Reverend Professor Ansa. And then we have Dean of College of Health Sciences, KNUST. The provost for KNUST, College of Health, is Professor Christian Ejare. Professor Christian Ejare. All right. Please, I might not know some of your names, but you can prompt me to mention them. You're all welcome to today's session. I don't know. We are supposed to wait. Okay. Now that Dean of School of Pharmacy, Lagos. I see a Dean. All right. Okay. Once the chairperson is known, can we start with the scientific?
Let's call the first abstract.
What?
A0.
A004. Once we wait for our chairperson, please come with the first scientific presentation. A004. Is there one presenting around? Please do it better for him to come. All right. Please, you have 10 minutes. All right.
Thank you very much for giving me an opportunity to make a presentation. No, that's not. This is not my abstract. Evaluation. Yeah. Edit this, make this A4. Yeah, then let's after
A0.
Yeah.
A0.
So you start.
Okay. So there was a little just looking for the slide. They found it.
All right. So abstract A004, please, can you lead us? Please, you have just 10 minutes, so be swift.
Thank you very much. Thank you for giving me the opportunity to present the title, Evaluation of Resident Clinical Pharmacist Intervention and Recommendation in Ultimate World of Kolebu Teaching Hospital. Next. The presentation outline will look at introduction, that's the background, study objectives, method, key findings, conclusion. Basically, the traditional role of pharmacy used to be basically for dispensing of medication both inpatient and outpatient. That is in the community and that of the hospital. But and as a result of that, the role of the pharmacy in the delivery of healthcare services to the patient was decoupled because we were not directly involved in providing service to the pharmacists. But as far as times go on, the professions has evolved to the extent that there's a need for pharmacists to get themselves involved in the provisions of pharmacy, and the need of pharmacist intervention in the delivery of pharmaceutical health services in the hospital. It therefore plays a very pivotal role for pharmacists to involve themselves in clinical service delivery within the hospital. Next. The main objectives of the study is to evaluate the number of medicine-related interventions and recommendations at the Lion International Eye Center of the Kolebu Teaching Hospital by resident pharmacists from the Ghana College of Pharmacists posted to that facility. The study was prospective and a single-centered patient charted reviewed and was carried out using a clinical pharmacy resident from the Ghana College of Pharmacy. It took a period of 4 months. Each of the recommendations was documented and categorized and analyzed for acceptance and non-acceptance by the physicians, ophthalmologists. Additionally, each of the interventions was classified and quantified according to the type of error identified. Next finding. The clinical interventions were provided by 2 clinical pharmacists under the supervision of a senior specialist pharmacist. The type of an intervention documented during the pharmacist visit were categorized into 2 main blocks, that is medication reviews and patient's compliance. The clinical pharmacy intervention was carried out at the inpatient ophthalmic ward and during pharmacist-led medication review. The primary goal of the clinical pharmacy intervention was to improve the patient's therapy. The key finding, within the 4-month period, 13 patients were reviewed. Yes. And the mean aid was 28.7 with a standard deviation of 6.1. There were 54% of females and 47 of the males. In total, 70 interventions were made with a mean per patient is 5.3. So these were the key findings. The most significant aspect of this one was just to see the interventions that were made, whether they were accepted, rejected, or they were not accepted at all. For instance, if you look at the number of interventions that were accepted were 5, that will give us 7.15%. Those that were rejected were 2, and those that with unknown acceptance were 90%. You make an intervention to a physician, you have a duration of 47 hours, whether they are accepted yes or no. That one is the discretion to the physician. You have no option to do that. Next slide. Next slide. But these were some of the errors that were detected during the study. The one with the highest was dosage frequency, and the least was wrong medication. Next. Next. In conclusion, clinical interventions were made, clinical interventions made were moderately significant and primarily related to medication use in the alternate specialty setting. Further study is needed to strengthen the outcome and improve the acceptance for the benefit of the patient seeking eye care at the eye center pharmacy. Thank you.
For him. Are the technicians around? It seems we are having issue with our microphone. Technicians, can you rectify our microphone issue for us? All right. Thank you very much for such an enviable presentation. Please do it better. Another round of applause for him. Once we have professors with us, we have academicians with us. This is a scientific presentation. If there are any queries, any suggestions, or anything that you think is at variance with the standard, I will take just 2 questions for the presenter.
I know it's a
All right. Please, are there no question for him? Are you all okay? All right. Okay. Once there are no other questions, I think I will take this opportunity to introduce the chairperson. The chairperson for this particular occasion is Dr. Sifa Bediakon. Dr. Sapong Sifa Bediakon, please do it better as he occupies the seat. All right. We will take an opening remarks from the chairperson. All right.
Okay. Good afternoon. Good afternoon. I know we just had our lunch, and normally after lunch it becomes a little tired, but let us try to keep our eyes open and enjoy the presentations. First of all, I would like to thank the PASGH executive for the opportunity to chair this occasion. It is a privilege to be here, and it has always been a privilege to be among pharmacists. And listening to the topics today, I've seen that we are marching to a right direction. If you look at the healthcare professionals that we have in the country, in fact globally, pharmacist is the most visible and the most approachable profession. In fact, we are the most trusted professions in the community and globally. So the track today, ways of improving community pharmacy practice is at the right time. Because if you look at the distribution of pharmacies and healthcare facilities in the country, you see that pharmacies are all over the place, and we are in the community very, very visible and approachable for the Ghanaian people. So people come to us first and foremost before they even go to anywhere. So discussing issues that will help us to improve the practice of community pharmacy in Ghana is a step in the right direction. And there's a lot of opportunities that are there. Listening today, we're talking about the professional fee for practice. This is something that other areas have fought for and they have been successful. So we starting in here means we are also going to be successful. Others have done to the level where they have MTM, programs, and we have the health insurance paying for our services. I think that is one of the areas we are heading to. What I would like to say is that the presenters have done a great job, and they are going to take us through the various presentations, scientific presentations that they have. So I wouldn't take the words out of their mouth. All I would like to say is that I thank you all for this opportunity, and let us all try to keep our eyes open, because after lunch normally becomes a little difficult for us to stay awake. But the presentations, I can guarantee you, they are very interesting. So let us open our minds and open our eyes and listen to that. And let us all contribute so that we can come up with a very comprehensive guidelines which can help us deliver pharmaceutical services in the communities that we live. Thank you very much.
Oh, I bet person. My speech was that we are the most trusted profession in the world. How are we doing to maintain such trust? All right. The next on the list is RX Info. RX Info. Please, are you ready? RX Info. Whilst waiting for them, let me take this opportunity to introduce the speakers. The speakers for this particular occasion is Dr. Vera, Farm Dr. Vera Dansa Asante. Let's do it better as she comes forward to sit. Yeah. She is by Farm Jewel Anaman. Oh, please, a better one as he takes his seat. RX Info, please, we are waiting. RX Info. I think one person said he had an. Okay, someone asked a question for the first presenter, so let's. Professor Wuto. Okay. Okay. Another one on the list is, please, sorry for this. Another one on the list is Professor Victor Wuto. Please join the seat. Oh, please, a better one for him. Thank you very much, sir. All right. Whilst waiting for our info, we will take a question from one of.
Okay. Thank you very much for this opportunity. I am Dr. Ibrahim Boating. My question is for the first presenter. From his presentation, I was well informed that most of the care issues that they were able to gather was from drug frequency issues. So I would like him to elaborate us on that. Those few care issues that they were able to gather, so that we also be well informed about that. Thank you.
Okay, so we'll have him answer the question.
Please ask the question clear, if he can come again.
Yeah. From your report, we realized that most of your care issues that you were able to gather was from those frequency issues, dosage frequency problems. So I would like you to elaborate us on that, some of the issues that you were encountered, and the recommendations that you did put across.
Yes, the most common care issue among them was the drug dosage frequency. Yes, and most that usually this is what happens in the settings. You know, Kolebu is a teaching hospital. So what happens is that the resident leaves the house offices. They go around, they write the prescriptions, whatever it is. So when you go back and take the patient chart and you deduct any K issue, now you check and you have to get the doctor informed. When you get the doctor informed, the doctor immediately effect the change. You have to go back, consult the resident, go and consult the consultant or the specialist before it is affected. And within, you have a period of 48 hours within which to be done. At times, some of the consultants are not available. You realize that when you realize those that were not accepted were 90%, but they were K issued. But you, the pharmacy, have no option whatsoever to change anything unless you liaise with the doctor and the doctor agree that and he effect the change. Yes, and that is one of the K. Yeah. Yes, there was a case that someone was having orbital cellulitis, and we realized that the dose was calculated without taking into consideration the weight. Yes, so we drew the attention of the doctor to read that if per this week, the dose have to change to this, and he came to that. What, it was an antibiotic. It was an antibiotic that the patient was put on. Yes, and he have to change the dose and the frequency.
Thank you. So, like was said earlier, my name is Beatrix Iwa, and I'll be the moderator for today. So the question or the issue to be discussed today is creating opportunities in community pharmacy practice. And we want to find out new ways that as pharmacists, or specifically community pharmacists, we can go about our duties that would continue to create opportunities for us. So like was introduced earlier, we have Dr. Vera and then Farm Joel Animan being our panelists for today. We also have Farm Wuto joining us briefly, and then our chairperson as well. So I'll go on to give the mic to Dr. Vera. She has, okay, so Dr. Wuta is doing that now. So Dr. Wuta would take the place of Dr. Vera and give us 10 minutes presentation that he has prepared for us. Thank you, and I think he deserves a round of applause.
Thank you very much. Could I please have the slides on? Thank you. Was it? Oh, okay. Sorry, I can't hear. Oh, expanding the scope of pharmacy practice or something. Yeah, thank you. Yeah, we just was supposed to be an hour. Then it reduced to 30 minutes, and now I have 10 minutes. I will see how it goes. Cool. Like, you know, we've been listening to speakers, and I look around and I see all the pharmacists, that this profession has a bright future. Honestly, I look at it, and the kind of things we are doing, the kind of things we are thinking about, if we can put everything, if we can put everything together, this profession is going in the right direction. And we have a responsibility as all of us, as individuals, to do our part. Okay. Hello. I think this is better, yeah. Okay. We will do it as it is. How are we going? Good? Yeah, they did. Okay, so technically speaking, I was going to look at a few things that expanded scope of practice. And we were talking about a fee-for-service services. So I was trying to look at some of the services that we render that attract fees that either the government pays us or the patients do pay for that. So I'll touch briefly on some of them. One of the things we do which attracts a lot of money is what we call the medication review, okay? Now, in medication review, we have two types of medication review, the basic medication review and the comprehensive medication review. In the basic medication review, if you have a patient who is on one chronic medication and has a predisposing factor like obese, that kind of problem, they smoke, they qualify for regular medication. We have a regular medication review, but if you have a patient who is on 3 chronic medications, then they qualify for a comprehensive medical review. Now, when you embark on a medication review, whether it's the basic or the comprehensive, there are a few things you need to take into consideration. You are going to sit down with the patient and spend time with them, taking you away from your normal duties as a pharmacist. For doing that, you deserve to be paid extra money. That is not what you do on a regular basis. So if I'm going to take time off and sit down with a patient for half an hour, I need to be paid for that. That is the kind of thing we are talking about for fee for service. They come, they pick your medication, they have a conversation with them, side effects, that kind of thing. Deal, easy. But if you take me off my job to sit down with you for half an hour, you need to pay me extra for that. Now, in our case, the government pays us to do that. So if you're a non-resident of my province, then you need to pay me. So the basic med review, the government pays $60 per one. And they pay $100 for complete medical review, okay? So it's a huge avenue to make money, but also a time for you to recap a lot of. Because when I sit down with somebody to do a med review, one, you need to know any medication they are taking, whether prescription or over the counter, you need to know that. You need to know their allergies. You need to know their lifestyle, what kind of food they eat. You need to know, do they smoke? And now for us, now we have to include asking questions whether they smoke pot, marijuana. It's common all over the place, all right? You need to know all those features. You need to know all those things. And then, do they exercise? If they do, how often? How many hours? All right? So you factor all those into the equation, then so you gather all the information you need from the patient. And at a point in time, you also have to have, how is their sexual life like? All right? Because it's huge. Once you gather all that information, then you have to make a decision. At a point in time, you may have to give them a lab requisition to go to the lab and get a lab report for you. That is something we do, all right? So in order for you to have a complete picture and to make a proper judgment as a pharmacist, you issue a lab requisition, they go do the lab, they send you the report. When the report comes, then you sit down and they make a decision based on that. But you have to be comfortable with whatever you are doing. You don't just issue a lab request because you want to issue. You need to be able to read whatever the outcome is, okay? So I have to say this. You have a PharmD. Excellent. That is just the beginning of the road. All right? Currently, with our students from the University of Alberta, we are pushing them to specialize because that is a huge avenue to get them into different areas. So I was saying yesterday, I have had students travel for probably like from Tamale to Accra. So they leave to come and study because they want to study under you. That is where they want to specialize. All right? So like there was a gentleman talking about a specialization from the, yeah, I think that's the way to go. But it takes time to review all the curriculum and stuff like that, okay? But we need to start, oh, okay, that's all right. But we need to start from somewhere. So after this conversation, we need to start taking the steps to review the curriculum so that the students will decide where they want to specialize. And okay, I don't even know how I'm going to go back to this, but that's fine. It gives me a guide, all right? Okay. So I don't even know. Okay, let me go back to the slides quickly, briefly, okay? So I wanted to touch on the healthcare system. We are shifting, healthcare system is shifting from treating illness to managing health and well-being. It used to, somebody has malaria, you treat the malaria and get out, you're done. But now it is more than that. You're not just treating the malaria, because the malaria could have caused another problem down the line. If someone has malaria and he hasn't been to work for 3-4 days, he doesn't have money to look after his children, that is a complex system you have to deal with. You're not dealing just the malaria. That's how we look at healthcare now. Someone has diabetes. You're treating it fine. His blood glucose level is under control, but he has sexual problems. It's a problem that has to be dealt with. So you have to shift your attention from treating just the disease to the well-being of the patient, the quality of life of the patient. And one size fits all doesn't happen any longer in practice. All right? Community pharmacists are the most accessible health professionals. We've heard that over and over. And but you see, in recent years, it's becoming more complex because we have an aging community, aging population who are on so many medications. So the picture is not as straightforward. He comes to your pharmacy, he's on blood pressure medication, and then so you treat it, it's done. You have complex stuff to deal with these days. You could have a patient on about 7, 8, 9, 10 medications, and if you have to such a patient to do a med review, you know what it means. CP is the face of the profession. I know some other people will disagree with me, but that's the fact of the matter. The face of this profession is the community pharmacy. You can't run away from that. If you argue about it, you can argue about that, but we know it is the face of the profession. That is why I believe strongly that we have to do everything we can to protect community pharmacy. If the face of the profession goes down the drain, the profession has a problem. So we need to do whatever we can. Whether you are GOPSA or a REPI or whatever, if community pharmacy is not in existence, what is a REPI doing? All right? Ultimately, GOPSA and all those guys, they go on retirement or whatever, they will end up in community. That is where the pharmacy is. I wanted us to picture a situation where you always have a pharmacist have an interaction with a patient. They try to synchronize everything. Just picture that. This is a daily thing you do every day. You go to work and all these things are waiting for you. You have appointments to sit down with a patient. My regular week, you go to a week, you definitely have a clinic in the course of the week for me. There's no two ways about that. Always have a clinic. And my clinics, you have either you have a asthma clinic, COPD clinic, you have a heart clinic, clinic, where you bring a lot of the patients together to go over their medication, teach them how to do things. Now, I've gotten to the point now where I work with a respirologist in town. He diagnoses a patient with diabetes, asthma, COPD. He'll give them a note and direct them to my facility to prescribe, monitor, and if there's the need, you get back to them. This is how far we have come. All right? That is why I think it's important for pharmacists to start specializing. When you start specializing, everybody sees your value in the community. I know there's a lot of competition. The doctors are not happy about what our PharmD students and graduates are doing. That is it. It's not only in Ghana. Let's be fair. In Australia, they're having a huge challenge with the physicians. They are refusing to accept them because it's a huge thing coming that they don't know where it's going to end. So they have to protect their profession. So we also have to be very tactful about the way we enter the system. We've been in the back bench for too long. Now we want to enter. You think they will just accept us? No, they won't. You're not going to fight with them. If you fight, you lose because all the top positions are being manned by doctors. The promotion is not going to come. You can have a pharmacist as a deputy for 2, 3 different doctors come to take over the position from you. We have to be tactful about the way we go about it. One thing I also believe pharmacists have to do is we have to start spending money on lobbying. Most of those things we are trying to achieve, why should it take us over a year to get the government to allow us to give injections? Come on, let's be serious here. We are handing over injection to our technicians now. Pharmacists will pass that stage. And so we have to start lobbying. I believe that probably we should spend all our money from PSG, spend all our money lobbying to get us into the positions we need to be. It's nice to come here, spend money, and do all that kind of. Okay, I'll take care of that. That's all right. Good. So now the question you ask yourself is, what we are talking about expanded scope of practice, okay? And the question you ask yourself is, what do we need it for, and why do we need it for? And look, the way things are coming now is an opportunity to create jobs, an opportunity to learn and be smart and get to know what you are doing and enjoy your job. I enjoy pharmacy now. I do. All right? And once you start doing some of those things, pharmacy becomes very, very interesting, very, very challenging. So we need to get into the group of doing some of those things. And like I said, PharmD and beyond, so what? Doctor, whatever. I know some of you enjoy that, but that's fine. I don't care. Listen, anyway, yeah. So the current pharmacy curriculum provides you with the basic education that you need to become the managers of the pharmacies, all right? But what you need is you need a sound pharmaceutical-based knowledge, effective problem solving. That's those things. You can't just be a pharmacist by just knowing your theory. You need to be able to manage people, because you work in a pharmacy and you can't manage your staff. You're fighting with them. Disagreement will happen. You have to disagree, but you have to disagree constructively. All right. I manage a team of about 20 something, have about 5 pharmacists, kind of thing. There's always, they want to do the things their own way. But you need that ability as well. If you cannot, probably community is not yours. You have to go to hospital. Because in community, you're going to be interacting with patients, you're going to be interacting with your staff, and you're going to have disagreements. You need to learn those things quick. I hired a lady from India, and we're trying kind of having issues. So I had to go and take a course on diversity, how to relate with those kind of people. I spent a fortune on courses. Now I wanted to know to issue lab requisition and read it, spend thousands of dollars to take a course in that, so I know exactly what I'm doing. You need to spend money to develop yourself. Like the president was saying, it's good to make money, but you need to develop yourself first, especially the young ones, the entry level. Develop yourself. Once you develop yourself, the money will come. If you start chasing the money, you may make it, but you need to develop yourself. I'm not going to bother about it. That's fine. Now, I am a prescribing pharmacist, so I can initiate a therapy on my own any day. All right, you can, if you want to collaborate with somebody, that is fine, but you can initiate your own therapy. The government pays you for that, easy. All right, I mean, that's how far we've come. You initiate a therapy, so you sit down with the patient, collect data, whatever information you need, and move on from there. And you can collaborate if you want. You can have that's it. Yeah, if a prescribing pharmacist, you do whatever you want. Any drug you want to prescribe, you can. We had a limit on the hardcore narcotics for a while, but after COVID, we're allowed to do anything. So you can prescribe, have your own clinic. Currently, what we hit in the market now is pharmacists run walk-in clinics. So all you have a clinic, and all the people there are pharmacists. And so if you have a clinic, you have a certified respiratory educator, certified diabetic educator, travel medicine expert, cardiovascular expert. So you have a clinic, and patients just walking. You do your job. If you're not comfortable, you don't do. If you get somewhere, you refer. But we are running pharmacy-run clinics now because we're having challenges getting doctors in the system, and that is the direction we go. And we're happy with it. The government is happy with it. We are making progress. But before you get to that point, the government has to see your value because they're going to pay you for it. You can't just expect them to pay you if they don't know what you are bringing to the table. You're not politicians who get free money. You have to work for your money. And I'll give you 3 situations where prescribing is easy, all right, where you can easily prescribe. Now, effectively and appropriately managing acute pain conditions such as dental pain. Now, if someone has it, my time is up, right? Okay, thank you. Yeah, I like that. That's okay. That's okay with me. Yeah, okay. If someone has a dental pain, all right, it's on a Friday, dental offices are closed on Saturday, Sunday. Are you going to ask them to continue taking Tylenol when you could easily manage that pain with probably a prescription medication? What kind of pharmacist are you? And why should a patient have to suffer because the physician is not available? You have the knowledge, trained, you can do it, then you prescribe the medication for them. You prescribe and monitor. Okay? And somebody comes to your pharmacy, establish asthma patient, he's out of medication. You're going to ask them to wait for 2-3 days before they see a physician for prescription? Do you know how much it costs for them to end up in emergency? Now, a typical COPD patient ends up in an emergency. It costs the government over $200,000. Ambulance picks him up to the emergency. It costs the government over $200,000. So what prevents you from giving them treatment so they don't end up there? All right? And, you know, I don't know. If you have if you're an injecting pharmacy, you give an injection, all right? And you have a needle stick. You give somebody injection and you mistakenly the needle, pricks you. The person is an HIV patient. So you're going to look for a doctor before you get treatment? I don't know. The same way you can prescribe, you can start prescribing, the same way you should be able to stop a prescription. I was listening to the presenter, was talking about that you find a mistake, you have to look for the doctor. Okay, they'll say, no, I don't look for you. No, I won't look for you. At the end of the day, I have the patient at heart. I'll tell you an interesting story. A lady came to me one afternoon and they said she needed an extension of her medication. She's on thyroid, levothyroxine, all right? And then because her doctor was away, I look at this patient, we had a chat, and I realized that from everything she was telling me, there was something wrong with her dosage. So I check what we call Netcare. With Netcare, I can go there and look at your profile and look at all the drugs you've had, all the lab works you've done. I checked her profile and she hadn't had a lab work done. She hasn't checked like TSH level for over 1.5 years. So from everything she was telling me, I knew there was something wrong. So I issue a lab report, go get a lab work done. I said, I'm more than happy to give you medication. So that we call extension of, you extend the prescription that the physician has written. But you extend it on sound reasons. She went to do the lab work. Is that what I have? Probably that is it. I'll get that. So this lady went to do the lab work, and clearly the levels of this thing were so high. And because the typical symptoms she was telling me were simple things that I knew that there was something basically wrong. I issued a lab requisition. We got the results. Bam. Changed the dosage for her. Within a month, because normally when you change doses of thyroid, you have to wait for 6 weeks minimum, right? 4 weeks, I wanted to follow up with her. You see the results that so drastic. Why do I have to wait for a doctor? We need to start lobbying to get us to do all those things. But before then, let's get all the knowledge. Let's get it behind. And if a doctor writes a prescription for, let's say, amoxicillin for a child and is underdose or can't? Thank you. Now, so you receive a prescription for the physician, all right? And the dose is underdose. And you're going to dispense it, or you're going to ask the patient to go and see the doctor. What are you doing there as a pharmacist? The question is, why did you even go to school? You know the dosage rate. You know that. So what prevents you taking the weight of the patient and giving the medication? Why do you have to look for a physician to do that? Now, injection, I was talking about injections. These are injections I give on a regular basis at my pharmacy. Regular basis. Every week I have something coming out for them. All right? Regular basis. Now, in Canada, in Alberta, we've given about 9.2 million COVID-19 vaccines. Pharmacists have given about 5 million of that. So pharmacists are going to have over 50% of that, more than the public health nurses. Talking about med review, we talk about that already. And that is something that comes up quickly. Most times after doing my med review, you put the patients on blister packs. Make life easier. They know they have to take this medication afternoon, evening, bedtime, Monday, Tuesday, Wednesday, Thursday, Friday. So if they miss it, they know they have missed it. A lot of patients at that age, they miss medication. They forget, did I take it? Did I not? Did I take it? Instead of them calling to ask you, Victor, what if I took a double dose? Would that harm me? That is going to solve the problem for you. We do a lot of stuff, point of care, lab requisition, we do that. And then, what is it? So I was talking about this lady. So her reading, the first time she came was about, so the range is 0.2 to about 6, all right? It was about 17 point something. You put her, you changed a bit. She was on 200 micrograms of Centroid, right? And because of what she was telling me, I changed it to 225 micrograms. Within 4 weeks, the reading has changed from 16 point to 7.8. So when I was leaving for home, I handed over her to my colleague that I have 2 more weeks to go. You do another lab work. If the readings are there, you increase the dose a little bit. Easy. I don't need a physician for that. And the travel consult is another area that we need to tap into. If we are beginning to learn to give injections, travel consult is another area. That is when people who are traveling, they are going on vacation, you sit down with them and find out where they are going to, what medication they need, what drugs they need, what vaccines they need. You give them the injection. Big money, good service. Aluta. Okay, let's have a compromise. Compromise, 3 minutes, I'm done, okay? Start timing for me, my brother. All right, so I was talking about, I won't go back here. Travel, huge avenue. Virtually every week I have a lot of travel consults. Now, the reason I say easy is that, now somebody comes to you, he's going to the Bahamas. He has enough money to buy a ticket to go to Bahamas, all right? So I sit down with you, you're going to Bahamas, what vaccines have you had? What haven't you had? He tells me whatever he has, what he hasn't. Then I tell you, you're going to the Bahamas, you need this vaccine, you need the Twinrix, you need your typhoid vaccine, you need to take some antibiotics for traveler's diarrhea, you need your Dukoral. They buy them, easy. If he has enough money to buy a ticket to go to the Bahamas, he should be able to pay for his medication. Huge avenue. And it's easy because, look, the government of Canada has a website. You just go to the website, you punch in the destination of the patient. It gives you what they need. What do you need? That's all. Okay? So that's an area that we have to look at carefully. Once you start running travel clinics in the community, people will hear about you. There are a lot of expatriates in town. When they are traveling, they will come. Oh, yeah, God. Anyway. Therapeutic substitution. I know there's a very big issue for RAP. They complain about it, but you are trained as a pharmacist, and you should be able to do therapeutic substitutions. Regardless of what somebody's business is, that is their job. RAP go promote the business. That is their job. That's not my job. I'm a community pharmacist. I have the patient at heart. I change the prescription as I wish. I substitute based on the need of the patient, not because you need to make money. I don't do that. I don't care. Cessation, not a big deal here, but makes a lot of money for us. Preventive hair, we do a lot of those things. I'm not going to bother about it. And then that's what we are doing now. Pharmacists working clinics, big time. So you have hundreds of patients working in your clinic every day. You prescribe medication. For every prescription you issue, the government pays you $20, $25. So if you have 100 patients come through, you just multiply that. And they go to the pharmacy to buy all the medication. Just think about that. How far we can do some of those things. And the question is, I'm just finishing up, wrapping up. What is preventing us from doing all those things? What are the barriers? Number one, that's the legislative. We don't have the backing of the government. That is where we have to start spending money to lobby. We have members of parliament that we have lobbied. We call them partners of pharmacy. When we have a problem, we go to them. Now we have elections in Alberta now. We have sat down with all the candidates. You need to tell us what you do for us when you become the mayor. That is how far we have come. If you are not on our side, you're not getting our votes. But before you do all those things, there are a few things we need to know. You need to have the knowledge. You need to have the passion for it. We need to have the backing of the government. And we need what? Competencies. We need qualifications. We need funding and everything. And this is the shortest summary you will ever find, okay? That is my summary. Community pharmacies are going to be the place where care is delivered. That access to the learned intermediary, someone who can assess, evaluate, prescribe when appropriate, and even more importantly, refer when necessary. That is my summary. Thank you very much.
Oh, do it better for him. Is it? Is that was what? Oh, I wanted to be. I believe in equity. You see, I believe in fairness. But once the majority was, that's why I allowed it. I believe in consensus too as well. The majority takes the vote. All right. What's here? All right. Thank you very much. Earlier, I wanted our to come, but unfortunately they were not around. But I think they are in now, so they can come and spearhead their presentation. But please, you have just 5 minutes. 5 minutes. The time is 5 minutes. RX info. RX info. Please, are you around? Do it better for her as she comes. A very beautiful lady. Let me take this opportunity to introduce the presence of Bismarck Ata Ejapong, Director of Ghana. Yeah, Chief Pharmacist, Ghana is Pharmaceutical Services. Director of Pharmacy, not Chief Pharmacist. Director. All right. So, RX Info. Over to you.
Thank you. Thank you very much. Very good afternoon to you all. And thanks for the opportunity. It's my pleasure to introduce you RX Health Info Systems. So we are a health technological company. What we do is to develop softwares, and our aim is to ensure. Hello. Thank you. Thank you. So we develop softwares, and our aim is to ensure that these software. This way. So our aim.
Oh, it's allergic.
Come closer. Okay. All right. Thank you. Apologies. Okay. Hello? Yes, okay. So what we do is to help transform health service delivery through technology. And since 2015, we've been building platforms that power seamless engagement amongst patients, the providers and payers within the healthcare industry. Okay. Since 2017, what we've done is to build different platforms, and we've grown our presence in Nigeria, in Ghana, and in Angola. We have over 3,500 providers currently using our platforms within the healthcare system, and we've provided about 10 million individual transactions already, and we continue to grow. Some of the softwares we've developed currently are the pharmacy management softwares, which I believe is going to be very beneficial to all of you as we technology in service delivery. We have clinic management softwares, laboratory softwares, optical management softwares, and revenue collection analytics and insurance management softwares. And almost all major health insurance providers are using our softwares for their claim processing. And we have about 1,500 providers currently processing their electronic claims through our softwares in Ghana. We are very proud to be partnering with the Pharmacy Council and PSGH for the e-pharmacy software, the e-pharmacy system rollout. I believe you've all heard about it. And it's very simple to onboard on the e-pharmacy software. I'm believing that all of you would want to improve access to clients through the e-pharmacy platform. And it's very simple. When you go onto the PSGH website, you should be able to, with very simple step, onboard your pharmacy onto the e-pharmacy platform. And pharmacists can as well register on the e-pharmacy platform. What I'd like to end with is that RX is an African company. And we have programmers, and the team that we have understand the real issues in Africa. We understand the issues here in Ghana, and what we do is to make our solutions to respond to these needs. And we've been able to deploy nationwide scale softwares in Ghana, in Nigeria, and we continue to grow, and you can count on us. So if you want to contact us, the email available, you can reach us on that. You can reach us on the telephone number available as well. And we have a stand right at the right side of the auditorium. You can see the RX Health stand, and we have a team available to assist you. If you have need of a software for pharmacy management, we'll be able to help you on board. If you want to register for the e-pharmacy platform, we should be able to help you on board as well as a pharmacist and your pharmacy. And I look forward to having you all on board your pharmacies onto our various solutions. Thank you.
Thank you so much. So we'll go on straight to the discussion. We'll take a small presentation from Joel, and then we'll begin our discussion. Thank you.
So it's not really a presentation, but thank you so much for the presentation, senior colleague Uto. It was very insightful. And one thing, or some few things that I wanted to point out as well, was that I wanted us to take a look at our current situation, right, as pharmacists. In as much as we are going to have all these discussions, I believe that we also need to map out the kind of stakeholders that will be interfacing with all the decisions that will be here, all the decisions that will be taken here, and the decisions that will be taken when we move back into our facilities. And I want to highlight three main stakeholders. The first stakeholder would be the policymakers, the regulators, and then PSGH. I'm putting them under one bucket. This is because, as Prof. Uto said, most of the things that we are facing, most of the issues that we are facing are more regulatory driven. So if you're able to get these bodies to collaborate, we'll be able to develop solutions for patients. And it's not just at the individual point in our pharmacies, but at scale. So it's very important that we understand that. The second bit is the proprietors. I do understand that not all community pharmacists are proprietors, right? So it means that there's a disparity there. If I move away from here with a lot of innovative ideas and I don't get the support of the proprietor, then there's a huge blockade there. So there's a huge gap there that has to be bridged. And then the last one is for us, the practitioners ourselves. I might make a controversial statement, but I would want us to come to the fact that community pharmacy is a perfect blend of practice and business. So we need to face that reality. Till we decide to face that reality, we may discuss all the beautiful solutions, we may go back and not be able to roll them all out. So as we engage in the discussion, we'll be sharing our ideas, sharing statistics, and we hope that you also join us in the discussion. Thank you very much.
Please let's give it up for Joel. Thank you, Joel. So I'll go ahead with the questioning, and both the panelists will give their thoughts on the questions, and then it's good to let us know that this session is for us as pharmacists. So it will be good for us to comment as much as possible and ask as many questions as possible. So aside the panelists giving their thoughts on the questions, it will be good for us to also be involved as well. Thank you very much, and I'll begin with Dr. Vera.
No, I'm just, okay. Good afternoon, everyone. So I think I wanted to bring our attention back to our topic today, which is creating opportunities in community pharmacies. We are shifting or re-engineering the service paradigm. So we are moving away from our regular day-to-day dispensing and coming to what we are trained for. I think for the longest time, we have been focusing too much on the business aspect. And I always say this, we are pharmacists. We're doing PharmD now and being called doctors, and we still want to see ourselves as business like dispensers. And I think this is where this particular program or this particular symposium is very important for us community pharmacists to shift our mindset from this day-to-day dispensing into the service paradigm. And I believe once we start the discussion, we can all contribute and we can move forward to where pharmacy practice should be going in the community. Thank you.
Okay, thank you, Dr. Vera. So the first question is, how can we, as much as possible, optimize opportunities in the community pharmacy space in relation to the recent launch of the e-pharmacy?
So I think the e-pharmacy is a very laudable idea. It's long overdue. We needed that. We needed some form of digitalization. We needed some form of being able to have access to our patient, not just for them to walk to our pharmacy, but in a way to capture them. And the e-pharmacy provide that for us. So in as much as we may or may not want it or whatever our feelings are about it, I believe the most important thing is the regulation part of it, making sure that the framework actually fits into our what we need as pharmacists, as community pharmacists. But I believe the e-pharmacy has given us the opportunity to reach out to even a broader spectrum of patients that were not previously accessible, especially when you get into the remote areas. Though we're hoping that in the rural areas, they also have access to the smartphones and computers and whatever, that they will be able to access it and get their prescription. That is the hope that we have. So I believe it is something that is really great for us community pharmacists, and it's giving us the opportunity to have access or accessibility to our patients. Thank you.
Okay, so what I would also want to add in that regard is, I used to be a medical rep, right? I repped in Accra, I repped in Koforidua. On a daily basis, I was a pharmacy rep. I was mostly interfacing with community. And before COVID hit, there were some trends that I observed. I would say 8 to 9 out of 10 pharmacies that I engaged never had a client database. They didn't have a formal client database. We've said a lot of things. Dr. Ruto keeps saying that when we pay attention to these patients, they will keep coming back. But the thing is that there's a lot of competition in the market, right? We need to develop that attitude of building client database, nurturing our clients. And I saw that was a huge gap, particularly when the COVID hit. I was really wondering how pharmacies were going to survive without patients walking in. We need to get to the point where you are very sure that you have 100 pharmacies that you can even, 100 patients, sorry, that you can even engage virtually. Even if you don't open your pharmacy and you provide your pharmaceutical services, you add some delivery services to it, you are still able to extend some level of quality pharmaceutical care delivery to them. So that is one major opportunity that the e-pharmacy is bringing, because when you look at e-pharmacy, you are able to capture details on your patients. You're able to forecast because you get to understand the products that your patients are on, whether you have to do a switch. You can leverage various documentation systems to understand your patients better. And these are gaps that currently exist in our community pharmacy practice. So definitely e-pharmacy has a role to play. The last thing that I will add is with regards to herbal medicine, right? I know a lot of pharmacists do shy away from herbal medicine, but some of these herbal medicines do work. And the Mampon Center for Herbal Medicines, there are pharmacists who are practicing, there are pharmacists who have studied pharmacognosy in depth, and they're ensuring that products that are coming out are of the right medicinal value. So we have to take this opportunity to integrate these herbal medicine formulations and promote it to patients, because then it becomes like, okay, we are just focusing on just the orthodox medicines. And when we take a look at our patient demographics, you realize that not all of them are really settling for orthodox medicine. So that's just what I want to add. These are the opportunities that e-pharmacy will give us.
Thank you so much. I'm happy I've seen a hand in the air. So Prof. Boabing, please, you have the floor.
Thank you very much. Now, so Kwame Ohini Boabing, number 1115. Thank you. All right. Victor, thank you very much. Excellent presentation. And those of you who went to the Ghana College of Pharmacy, those of you who went to our stand, we are in collaboration with the Royal College of Royal Pharmaceutical Society of Great Britain, and then Health Access Network. And we have actually put together a program which is actually part of our curricula. And again, I'm taking opportunity to encourage all of you in community pharmacy who have not yet enrolled in the college to enroll and specialize in community pharmacy practice. There you get to get trained and develop competencies in areas like medication use review or medication therapy review, just like Victor said. So we are rolling out the program. I think we've shared the flyers. Maybe Dr. Ireland or the rector will talk about it. And I want to encourage all of you. It's a certified program and it's in various stages so that you develop all the knowledge, skill, and the competency to practice as a certified medication review therapy expert. Those in community practice, those who have enrolled in the college, both in Faculty of Clinical Pharmacy and Community Pharmacy, it is compulsory for you. Thank you.
Thank you, Doc. There's another.
Thank you very much. Stephen Bona, 1621. I think there's one, we are trying to misconstrue dispensing process to be giving out, like dishing out medicines, all right? So when pharmacists say we have been reduced to dispensing, the dispensing is a process with a lot of components. So first of all, what's the process? You receive prescription and validate. If somebody comes to that prescription, what do? You use WHO's, whatever it is, to ascertain, all right? What's the next step? You read, understand, and verify. There's a lot of things that goes into verification, and we need a lot of knowledge even in that area. What's the next step? That's where somebody goes, collects labels, brings out. After that, what's the next step? That's where somebody verifies. So here, some of these pharmacies have a two-way dispensing process, where the person who receives the prescription is different from the person who gives the medication to, so that you check to make sure there's no mistake. So I think that even the dispensing process, before we come in, so the counseling aspects, when you are giving, How do you cancel the patient? The medicines are in front of you, isn't it? You take the medicine, the person has malaria. And this is for 3 days. This you do ABC. This is for your pain. This is for a loss of appetite. So I think that let's not limit the dispensing to just dishing out and think that. Hello? Yes. I think that what if we are not dispensing, which if you are doing it well, it's exactly what we do in community. So please, I think that let's disabuse our minds about that dispensing is an issue. Thank you very much.
Thank you.
Can I just comment on it? I don't want you to misconstrue the dispensing aspect as to just giving out the medicine, because it takes a lot. I mean, if that was all we did, then MCAs and technicians can just do that. What I'm saying is that that's not what we are all about as pharmacists, because it goes beyond dispensing. There are many more clinical things that we can do in our individual pharmacies beyond dispensing, and that's what I'm trying to drive to. Our topic today is talking about what opportunities can we create in our pharmacies. We talk about MTM, we talk about fee for service, we talk about vaccination. That's all different things, services that we can provide within our pharmacy, and that is not considered dispensing. So when I say dispensing, that's one aspect of things that we do, we as pharmacists do. And believe you me, that's what most pharmacists think. I have a nephew that told me, came to my pharmacy and saw all that I'm doing, and I say, oh, Auntie Vera, I didn't know you guys did this, you did it. I thought you only give medicine. So are we only subjected to dispensing? No, we do a whole lot more than that. So that's what I wanted to draw our attention to, but not just the dispensing, because that's part of our job. And it takes a lot to dispense. Thank you.
Okay, I think there's another hand up there.
She said that's the last one. Okay, but gender balance. So from here, I might go to the other end.
All right, my name is Fred. I just want to make a contribution to what's just being discussed. Dispensing is both a process and an act. Okay, so we are not wrong if you say that dispensing the act, because it's an act. If I give something out to somebody, I've dispensed it. And then there's a process of doing the dispensing. The sad reality, which sometimes we tend to overlook, is that we can't deny the fact that some of our colleagues, I don't have data, so I can't give a percentage. Some of our colleagues have really limited it to the act of dispensing, not the process of going through the dispensing. I can mention names around. I've bought medication around the Confanochi area. Actually, when they gave me the medicine, I asked to see the pharmacist, and they pointed out the person who gave me the medicine was the pharmacist. You understand what I'm saying? Because they took it to her and she wrote on it, and then she gave it to me. The normal thing, thing. And then so I asked to see the pharmacist, and they pointed out that she is the one. So let's not hide and run away from that fact. It's a reality. Let's face it, address it. If we even do the dispensing process well, the society we are in will see a certain value to the pharmacist. Thank you.
Thank you so much. So we move on to the next question.
Last one. Yeah, at least.
Hello, Dogbeda. Please, mine is on the e-pharmacy. Anyway, it's a very good initiative, and we all want to have the e-pharmacy. When it was launched by the Vice President, I took the chance to go online to see some comments that people made about the launch of the e-pharmacy. And some of the comments, about more than 3 or 4 comments I read was, okay, they don't even know what they are doing. Look at our rules. They now added e-pharmacy. To do what? So if you are able to get them, you say, okay, you sign in for the medication, and they are going to transfer the medication to your destination. How are they going to travel from destination to the other destination. Why the roads are so bad to the extent that you cannot even move in some small minutes or some few minutes. So what I wanted us to look at, as much as we are going in for the e-pharmacy, we should also, if you are supposed to target or put pressure on the government or how we are going to do it, but you have to look at how we are getting the drug to the patient and our roles. I don't know. Thank you. Yeah.
Thank you so much for your comments. So our next question is, okay, so I learned there are a couple of us online who may also want to ask questions. So it's just for the online pharmacists to let us to know that we are aware they are online and they shouldn't hesitate to comment or ask questions when they want to. So the next question is, I believe that regulation of this profession is not for just a particular body to be in charge of. So I want to find out that should pharmacists be involved in regulation of this profession, and in the sense that individually during our day-to-day activities as pharmacists, should any onus lie on us to one way or the other regulate the profession?
Hello. Okay. There is no way to be regulated by any other person other than a pharmacist. Like, it's like having a church and then inviting a fetish priest to come and lead the church. It doesn't even make sense. So definitely, I mean, they are supposed to understand the practice. They're supposed to understand the profession. And so it only makes sense for pharmacists to be the regulators. Of course, it's when it comes to regulations and policies, it becomes, and whenever politics are involved, people tend to change, behaviors changes. Of course, we can't fault them for that. That is the natural process and human behavior. So we can't really fault them for that. But I believe strongly that pharmacists should be part of regulation. Now, I think you are more focusing on as even, let's say, Pharmacy Council is the regulator. Should us pharmacists also be involved in the regulation part? As far as when they said there must be a pharmacist in the pharmacy at all times, should we comply? And yes, because if we don't comply, if we are not complying to the regulation or the policy, then we ourselves are doing ourselves a disservice. And so as pharmacists, in as much as maybe some of the regulations are not comfortable for us or does not suit our business model, I think it is important for us to be part of the regulation and also comply with the regulation. We cannot, the Pharmacy Council or the regulators cannot do it alone. And we as pharmacists has to be part of the solution. If we are continuously breaking the law, then it is hard to continue regulating, and we end up having some of the reputations that we have with, within the community. So I think it's very important to have regulators. We talked about, Prof. Wuto talked about some of these services that are provided, and I think it's all about regulation. If we're going to do MTM, if we're going to do vaccinations, if we're going to do any of the fee-for-services, it has to do with regulation and policies. And of course, who best understand that than a pharmacist? So we have to be part of that whole process. Thank you.
Thank you, Dr. Byra.
Thank you very much. I just have probably a different view about those pharmacists being involved in regulation, okay? Now, I am a pharmacist. I'm working as a pharmacist. There's a regulator. They have to do their job. I can't do the job for the regulator. I have a role to play in that because the regulator is protecting the community and regulating the practice. So if at the end of the day, the regulator says that there should be a pharmacist in the premises every time the facility is open, I just have to abide by that. Okay? If I don't, that's why sometimes I find it very strange that a pharmacist, the superintendent pharmacist will not be in the premises. The risk you are taking is so huge that could end your career. If in your absence something happens and you're not there, that is a big deal. It may not be a big deal today, but it's a matter of time you're going to get into trouble. So I think we should look at it carefully from that point of view, because if you are the superintendent pharmacist, you are not on the premises. An incident happens, someone dies. It's your responsibility. You are the superintendent. So when we just hang our license and go away, we are taking a very, very huge risk. Then another question comes into play. Now, it is a regulator's responsibility to make sure that the pharmacies have pharmacists on the premises. If they don't do that, why do you blame the pharmacist? That's another question altogether. If the regulators are not doing their job, why do you expect the pharmacists to do their job? I have always argued strongly that, look, we know there are chemical shops around. They are selling prescription-only medications. All right? We know it's happening. Now, if the regulator is not regulating that, why should you? If you are not regulating the chemical shop where they are selling prescription-only medications and you know it is happening, you don't regulate that, you want to regulate a pharmacy? I have a problem with that. Let's treat other fairly so that the profession will grow. You can't take sides. If they need partners in regulation, yes, we can be, but you also have to do your part, so we do our part. That is the view I have about this.
Fantastic.
Hello. Okay, I think we have heard a lot about different things about community pharmacy. Let us not forget, we are trying to find ways to improve community pharmacy in the Ghanaian environment. All of us sitting up here, we have practiced pharmacy in other areas. And I have seen how we practice pharmacy here. Now, the Canadians are probably way ahead of it. And the US, we are following, or probably we are par. Ghanaian pharmacy, we are also catching up. But there's a fundamental principle that we all have to understand. For us to be able to improve and to attain the heights others have reached, first of all, Dr. Wutu said, the knowledge base is key. We need to have the knowledge base. If you do not, for instance, if you are at the hospital floor and you are bonding with the physician and you cannot make meaningful contribution to the team, you will realize that, there's nothing that you say that they will take. But if they know that you know your stuff and you come up with clinical evidence to support what you're saying, then, even when you are not there, they'll be calling for you. Now, let us come to the community situation. Pharmacy is currently moving towards clinical initiatives, both in the community and hospitals. Now, here in the Ghanaian situation, for us to be able to do pure good clinical pharmacy, we need data. You need the lab information to be able to do it. I'm with Ghana Health Service. I've gone around the country. Ghana, I've gone to almost every region. And I've visited a lot of facilities, hospital facilities. Anywhere I go, I look for ways we can improve pharmaceutical care in the hospitals. And I see the biggest challenge we have is the lab information, getting laboratory information. Potentially the the regional hospitals and the teaching hospitals might have the tools. There are some few regional hospitals that I've been to that they have state-of-the-art laboratory where they can even do cultures and sensitivities. Most laboratories you go, they don't even do that. They don't even have the capacity to do it. So even if you are a pharmacist and you are in those areas and you want to pursue clinical initiative, antibiotic stewardship, renal dosing protocol, IV2PO switches, all those initiatives that we know, it becomes virtually difficult. And you see that the practice there is basically empirical. Up to see now where we have to move to patient specific, it becomes difficult. Now, in the community situation, we have to remember, anytime we dispense medication to a patient, anytime, the body has to metabolize the drug. And how is it metabolized? It goes through organs. Either go to the liver, it goes through the kidney, we all know P450 enzymes. They have to take it, this one, all the isoenzymes, they have to come in. And if, like you said, if you have multiple drugs, it becomes more complex. Now, in the community situation, even in the US and Canada, sometimes it becomes difficult because obtaining the lab information is not easy. Maybe the Canadians have a way of getting it. Americans, as far as I know, sometimes it's difficult. Yeah, he said you can't. In the Ghanaian situation, there is a tool that I have seen very useful in the community that we potentially have to explore that. And it's a partnership with Redbird. Redbird is giving us a lot of clinical tools that we can potentially use to practice in our community pharmacies. We have the opportunity of making money by doing labs in the pharmacy. Once you have the lab information, your knowledge base has to be there for you to be able to interpret the data and see what you have to do. And then if you, as a pharmacist, if you have to make any interventions, the interventions have to be clear. And if it's something that is beyond us, we need to refer to the next level. Now, Dr. Uto also said something. We can, as a pharmacist, get all the knowledge that we have. Good thing that we have the college, which is providing us with the knowledge base. We have the pharmacy schools and pharmacy institutions. To be honest with you, all the information that universities give us is basic. She can tell you, in America with PharmD, you cannot get a job in a hospital. You can never have a job in a hospital in America with a PharmD unless you obtain a residency training. So we are getting there. We will get there. But the little initiatives that is available here that we should be able to use, we have to take advantage of that. Sometimes the business take ahead of us. And if we are not careful, we will lose out because the initiatives that we have to do to prove our worth, sometimes we let the business take it over. So here we have Redbird partners with us. A lot of the labs you can do at the various pharmacies, and you charge for it and you give it to the patient. You have a database. You build a database. You can build a database for almost all your customers, and you can follow up with them, let them do their labs, and all these are initiatives. So please, we are moving towards the clinical arena, both in the community and in the hospitals. So our mindset has to be moved towards that. Our mindset. As we do the business, let us also push for the clinical initiatives and our leadership, our pharmacy leadership, and all the our resource persons who are in leadership positions. We should be able to lobby. See, Americans were able to do certain things not because of PharmD that they get. It is because of the lobby potentials that they did. They have to be able to lobby senators here and there to be able to come up, get their support. And then the law will be passed. When a team is running, the pharmacist has to be on board. It is a law. You cannot do anything about it. But the thing is in our hands. It is in our hands as professionals. Unless we take those initiatives, little things that we see, to move the thing forward, they will always be boxing us. And we have to get the tools that we need to be able to box back. And it is through knowledge, and it's through clinical initiatives, and it's through lobbying. Thank you.
Okay, that's wonderful submission from my big boss, the chairperson. So, yes, we'll attend to that. But I just want to find out, let's approach this through lenses. So, okay. So, I just want to find out, can anybody guess how many inspecting pharmacists exist in Pharmacy Council for the whole country? Can anybody guess? How many inspecting pharmacists we have? How many inspecting pharmacists do we have? Can anybody guess? The whole country, how many inspecting pharmacists do we have at Pharmacy Council? Oh, it's supposed to be a guess, so you can guess. Okay, I can see 10, I can see 16, I hear 12, I hear 1, I hear 5, 20, 45. Okay, so we have 23 pharmacists, 23 inspection pharmacists for the council across the country. Can I think the mic is breaking. Yeah, so we have 23 inspecting pharmacists. Well, I have a business analytics background, so I'm going to approach it from the analytics perspective, right? So just a bit of data. We have 23 pharmacists, right, running inspections. Who can also guess the number of pickups that the Pharmacy Council has across the country? I hear 20, I hear 50, 10. Okay, you are quite close. So the Pharmacy Council has 11 pickup trucks, right? So we have 2 in Greater Accra. I mean, I'm not saying I'm not Pharmacy Council. So we have 2 in Greater Accra. We have 9 across the remaining regions, according to the old demarcations. So we have 23 pharmacists, right? That's already a constraint. Then we have 11 pickup trucks. They need to use these trucks for work. You get the point. Now, let's look at the total number of facilities that have to be inspected in a year. So far, we have over 20,000 OTCMS. 20,000 OTCMS across the country. We have about 4,200, a little above 4,200 pharmacies across the country. So that brings us close to 2,500, right? Okay, I'm not really good at math, but my basic math made me understand that if Pharmacy Council, with this current resource, with this current staff, want to run inspections and they have to cover all these 25,000 pharmacies, what they have to do is that they have to visit 9 pharmacies every working day. Each of these trucks, now forget about even the number of pharmacists that are inspecting. Each of these trucks have to visit 9 pharmacies per day, right? To cover the whole 25,000 pharmacies in a year. Just one visit. So by the end of the year, with this current staff, a Pharmacy Council wants to ensure that they are visiting a facility once across the whole year. They have to make sure that they are visiting 9 facilities a day. So what I'm trying to do is that I'm trying to paint the realities, right? These are the realities on the ground. And I understand there are a lot of issues with data and availability, so we are not able to really picture the kind of situations that we are facing. If you want to tackle this fundamentally, as we said, we talked about lobbying. Our lobbying strategy should involve getting more inspecting pharmacists employed. That is one. The other bit too is about the resources, right? The resources. Imagine 11 pickup trucks. How would they be able to do that, right? Great. Now let's take it to the next level. We've spoken a lot about OTCMS being competition to pharmacists, right? And we all agree to that. We have 20,000 OTCMS against 4,000 plus pharmacists, right? And if we are all agreeing that the OTCMS is the issue, the biggest issue that we have as pharmacists, that is impacting the way we are able to get customers into the pharmacies, then we have to start thinking about solutions. So for me, I mean, this is just a concept that you can think about. The PSGH and the Pharmacy Council have to work collaboratively, right? So imagine a community watch system. We do have policies in our communities, right? But in areas where there are huge crimes, communities take it upon themselves to have community watches. Why? Because if the police is not enough to take away your crime, would you sit there hand-folded? No, you find solutions to them. So let's look at how we can collaborate with Pharmacy Council. We have 20,000 OTCMS. Let's hold on with the pharmacists for now. We have 20,000 OTCMS. Can Pharmacy Council help support, visualize these OTCMS facilities across the country, right? So that you're able to understand that if you stay at Oyarefa, there are about 20 OTCMS facilities close to you as a pharmacist. If you stay at Ofanko, there are about 10 OTCMS facilities close to you as a pharmacist. Then the next step as a community watch is that we need to approach this from a data gathering perspective, right? So we always say that you go to the OTCMS facilities and they are selling prescription medicines. But if you ask anybody if they have data, there's no data. You get it? And if you want to push our advocacy, if you want to ensure that we are arguing from a point of fact, then we need to understand these basic principles of ensuring that we are adding data to our argument. So imagine that we say, okay, from Pharmacy Council and PSGH have agreed for this to happen. From January 1st, 2023 to June 30th, 2023, we are championing a research for ourselves as community pharmacists, right? Every pharmacist in your neighborhood, just try and go to an OTCMS facility, try and purchase a strip of penicillin, get the evidence, record it in a portal. For 6 months, are we saying that we won't be able to gather the data that will drive this advocacy for us? I want to hear the response. Are we saying that we can't get the data to drive this advocacy for us? Yeah, so exactly. These discussions feel very uncomfortable, but as we said, we are doing a paradigm shift. Paradigm shifts are not comfortable. And if you are looking at generating solutions to really strengthen regulations, then let's start looking at solutions across these lenses. Thank you.
Thank you so much, Joel, for that contribution. Okay, there's a question up there. We'll take it.
Very much. Interacting with some of our young pharmacists during their lunch break, there's some thoughts that is going around, and that is what is informing this question I've come to ask. And I need a distinguished panelist to help us address it. This professional fee for service we are proposing and attempting to roll out very soon, that fee that will be charged, does it go to the company or to the practitioner? Thank you.
Thank you for the question. I think.
All right. Someone want to help from me?
Thank you very much. I'm Michael Kofi 1456. Okay, so I had a stint in the United Kingdom where I did some small practice. In the pharmacy that I worked, at that time in 2008, every prescription that we served, we received, or the company received, £7.10p. Okay? So assuming we do 100 prescriptions, that was about £710. Hello? The local pharmacist who was coming there was taking about £200 from morning till 5 p.m. Okay, as locum. So the company is able to pay £200 every day and can still make about £510 profit, which could be used to run the company. So in that case, the money wasn't going to the pharmacist. The money was going to the owner or the company that employed him. But a percentage of it is used to pay the local pharmacist who was working at that facility at that time. And that is how they were able to generate money to pay some of these things. You are not the owner of that pharmacy. It's somebody's investment. Thank you.
All right, thank you.
Hello. So it is true, I am not the owner of the business, but I'm bringing money to the business. I have, sorry. Okay, so look, this is what happens. In most facilities, the money goes straight to the business, okay? Because you have hired as a pharmacist and you are doing your job as a pharmacist. And you are being paid as a pharmacist. What is happening now with most facilities is that based on all the other things you do, at the end of the year, they have all the data on how much money you generated and everything. They give you a percentage as a bonus. Okay? So you get a bonus at the end of the year, and that is based on your output or how much you brought in the facility. Now, I also know some pharmacists who go to work. They go to a facility and all they do is med reviews. So they sit down for the 8 hours and do med reviews. They take a percentage of that money and go away. They don't work for the pharmacy. They just go to do med reviews. So they are just paid a percentage of whatever money they get. But the truth of the matter is that before you even get a job now as a pharmacist, you can't just be just your basic pharmacy. It's not happening. I hire you because you can. Thank you. Because you can bring the money in, you give injections, you do med reviews, you run travel clinics, you do all those things. That's the only way you're going to get a job now. And look, I have a pharmacist who doesn't give injections. At the end of the year, he gets basically nothing as a bonus. But all the pharmacists who do the med reviews, the injections and whatever, they get a big package to take home. So, and now if you don't have any of those skills, you're out of school, you have your basic degree, it is very tough to get a job now. So you are paid as a pharmacist, it is a negotiation along the line. Thank you.
Okay, thank you.
Okay, I just wanted to add to Prof. Wuto what he said. You know, whilst we're coming up with the guidelines for the fee-for-service, this is something that, came up and is very controversial. Back in the US, when you're working, I remember where I used to work at, we're doing all kinds of clinicals, doing MTMs, and for each MTM service that we do, we make anywhere from $20 to $50 for one patient. And you can even make more based on recommendations. But at the end of the day, all the money goes to your employer. I remember doing vaccination, immunization clinic for a whole county, and for one particular season, I vaccinated over 2,500 patients by myself. And they made over $100,000. And at the end of the day, they just gave me a certificate and an award and put my picture on our website, and that was the reason, that was one time that motivated me to start my own pharmacy. But, they built their business towards that. And as a pharmacist, if you're going to work, your qualifications, can you do this? Can you do that? If you're not able to do it, you may not be hired because there are many fishes in the ocean. Do you know how many pharmacists graduated it just this year and last year? So we are moving towards, the clinical phase, whether we want to, and we really want to incentivize our pharmacists for the services that they provide. But let's not be too focused on the money aspect, but also on the experience and the skills that we are advancing ourselves with. And at the end of the day, if you work with a reasonable proprietor or pharmacy owner, I think you can come up with some kind of, compromise at the end of the year. I think having a bonus at the end of the year and making sure that you have that in writing, I think is important. Maybe PSGH and CPPA will also look at the guidelines and see how best we can also put some guidelines in place so that, we know that our pharmacists are not getting cheated for the services that they provide and also being incentivized for the services they provide. Thank you.
Wow, thank you very much. Joel, I want to speak to the earlier submission that you made. That was so insightful, the data that you presented. And I'm speaking as an academic. I think the information you provided, you can easily put it together. You gave us very good data, which pointed a direction, all right, that there is a challenge with regulation and because of the resources available. And perhaps they may meet the need, for Pharmacy Council to collaborate, all right, or work together with Pharmaceutical Society as it used to be done in the past. And regulation was very, very effective. The regional chairpersons and the district pharmacists were all involved in regulation to support the Pharmacy Council. I'll be very, very happy if you can put it together. I'm sure the College Journal will pick it, because that's a very, very useful information that you provided. Thank you.
Thank you. Okay, so the next question, looks like there are. We are running behind time, so I think we can. We'll just take two to the next one.
Okay, so my name is Albert, and I want to make some comments on what Joel said. I think the truth of the matter is, if we allow pharmacists to regulate themselves, I don't think it will work. And the reason I'm saying this is that we are humans, and some of us tend to love money. So if you say we should regulate ourselves, that's not going to work. And I believe that 50% of the problems in the community is due to regulation. Why am I saying this? I think I've been in the community for about 4 years. The first 2 years I was at Nkranza. I don't know if you know Nkranza. Now when I went there, that's the only pharmacy my boss could afford to pay a pharmacist and also work there. And when I went there, I have to do a whole lot of clinical things. But look at the system. They are used to the chemical sellers. They go in and then get their medication. When you went, you started to do the good thing. Now, the sales they were making have started to drop. As a businessman, what will you do? You have to sack the pharmacist because he has come, and instead of him to increase the revenue, he is actually making the place go down. Just because the people feel when you come, you are asking too many questions. And this is what is happening on the grounds. Not in Accra. I'm talking, I went to Nkranza, it's a nice place, but it's not like in Accra. And the pharmacists, there were only 5. And I was the only pharmacist in the facility. So if you start to do the right thing, I'm telling you, at a point in time, the people won't come to you. But then after some time, when I was doing it, now they started coming. But then the other 4 pharmacies who were not having pharmacists, they were still making it. And the business people wouldn't mind not hiring pharmacists. Because at the end of the day, they are making their money. And the regulator too is not checking them. Now, you said that you have about 20,000 over-the-counter facilities. But the truth is, they are all in the urban areas. I think there is a reason why the Act said that when there is a place where the people can have access to pharmaceutical care, there is no need to establish a drugstore. But here is the case, they are there, and these people are just around us. So you can't make the money. You can make all that you are saying, but then that money you get, for you to get that extra money to pay the pharmacist, becomes difficult. So
I completely understand.
If the regulators are not doing their work, with all that we are saying, and then let's look at it this way. We've been given a certain opportunity to regulate pharmacies and then the drugstores. We are not doing it properly. And now you are saying that we should allow pharmacists to inject, to do that. What is the probability that you can regulate that one very well? So maybe when we go to lobby, they will say that now you are asking for more. So if we can't do our homework well, I think all these nice things that we are saying may not come to play. We can never see it because they will not even allow us to do it. Because injection count.
Yes, so I completely understand the realities, right? I, for instance, at a point in time, I worked with a company called Sanisphere, and I worked in Kumasi. I came to places as far as Abrepo, right? And you get to see how like these realities exist. So maybe I didn't communicate my point clearly, but the main thing that I wanted to highlight, as I mentioned, is that in the meantime, let's hold on with even pharmacies. We are saying that OTCMS are the common enemy here, right? That's what we all agree to. So exploring solutions. These solutions are not final, but they're supposed to help us think about the possibilities. I never knew that in the past, Pharmacy Council and PSGH used to collaborate to help with regulation. Through these discussions, we've seen that there's a possibility here, and these are what these discussions are supposed to bring us to. You get the point? So whatever we are discussing here may not necessarily be the final solution, but it's supposed to inspire us to think about the possibilities that could exist if we decide to do things unconventionally. So I completely understand you. And of course, we have to, re-engineer solutions that would work for us.
Thank you, Joel, for your submission. Yeah, so another question.
Thank you very much. My name is George Boy. I beg to differ with the last comments. Self-regulation currently is most needed. Now, prior to this AGM, I had a staff and a customer walked in to request for chloramphenicol capsule. Apparently, she has been advised by the friend that she could mix with milk to manage STI. By kind courtesy, Dr. Sam, Ellen Sam, with the police hospital. I had seen, of course we know, but I saw recent pictures of these reactions. So I had it on my laptop. I invited her, come and watch these pictures. You tell me you are going to use chloramphenicol capsule mixed with milk to manage your STI, which is recurrent. Have you been to the hospital? No. Would you want to go to the hospital? I'll waste a lot of time. So it's very true. Unfortunately, or fortunately, in my absence, the sales recorded is higher than when I'm unavailable. Please, when I'm available, yeah. We have to attack this monster as pharmacists. Please, let's not look at the money. Please, let's not consider the money. Yes, there's a business bit, but you've been trained as a professional. And maybe a little testimony. Today, your reward is like this. We told the teachers, your reward is in heaven. Perhaps today, you're not recording it, but in the near future, you get something. I had recently visited Israel, and it was due to customer service. I had free accommodation
I was fed, or I was hosted because of the customer service I rendered. So please, it's of course economic hardships, and I side with Prof. Uto. We have to lobby. We have to lobby. And our issues now is a suggestion I'm making, or a comment. It's multifaceted. I've interacted with colleagues in regulation, Pharmacy Council. Some colleagues are regional managers. They tell me, George, we admit applications, and these applications have signatures of pharmacists on them. If we go for inspection or conduct site inspections and they meet the criteria, why should we turn them down? Private clinics, private hospitals, HEFRA insists that a pharmacist, if you want to dispense, in Koforidua, we are fortunate, you have one Reverend, Neti. His is only to consult, give prescriptions out, and then he goes to a community pharmacist. But some choose to dispense. And by HEFRA standards or laws or guidelines, a pharmacist should be there. Same pharmacist. We pen our signatures there, and then MCAs are manning the pharmacists. Self-regulation, please, let's attempt it. Thank you.
Yeah, I think because of time, we will be unable to ask the other questions we had planned to. There are other questions that have been posted online, and we'll attempt to answer two, and then we can call it a day. Okay, so Joel will take the first one. Please, with the introduction of e-pharmacy, what happens to a pharmacy located in a place with less traffic and population? Must they be on board? So Joel, take.
That's a very interesting question, because the whole idea of having an e-pharmacy is to still be able to make revenue if people do not walk into your facility. So if you're in that segment, okay, the question is solved, but if you're in that segment where you have low patient traffic, right, in your facility, and maybe you are even remotely located, that should be an opportunity for you to take that, seize that opportunity, get your product online. Social media is free. I see a couple of pharmacies on Twitter. I see a couple of pharmacies on Instagram. So far, those things are happening. They have Twitter accounts and all of that, right? And e-pharmacy is coming in to make sure that we are regularizing these things. So if you are a pharmacy and you are remotely located, you're not getting patients walking into the facility, this is the best opportunity for you to go on there so that you don't need people to walk to you, but you can send the service to them. That's where we are headed to when it comes to technology. So I hope that's the question.
Thank you, Joel. Please, the next question, if it can come. Okay. Prof wants to talk.
That's a very interesting question, and this is my view about it. With pharmacy practice, we have community pharmacy, we have hospital pharmacy, industrial, we have academia, medical rep kind of thing, all right? So we all go to school, we come out as pharmacists. I choose to be a community pharmacist. You want to go into hospital, you want to be a rep. Now, at a point in time in Ghana, we didn't have enough pharmacists. So they were allowing hospital pharmacists to be the superintendent pharmacists of their own pharmacies. Professors are been doing that. I believe strongly that we've gotten to a point where that has to stop. If you are a professor at the university, that is the path you have chosen. You cannot be a superintendent pharmacist and be a professor at the university. You can be a local pharmacist, but you should not be allowed to be the superintendent. If you're a hospital pharmacist, that is the path you have chosen. You work there full-time as a hospital pharmacist. You can be a locum at your own pharmacy, but not the superintendent pharmacist. It's controversial because our colleagues, they make money out of it, but if you look at it holistically, in the interest of the profession, it should never be done. They did it at a point in time where we didn't have enough pharmacists, so this was allowed. Now we have thousands of pharmacists being produced every year. That has to stop. Let's respect community pharmacy as it is. Being the hospital pharmacy or academia is no more important than the community pharmacy. Stick with what you are doing as a full-time, practice as a part-time, but not the superintendent pharmacist.
Okay. Thank you, Prof. I think that answers the second. It does answer it, yes. So we've come to an end of this discussion. I hope we've been able to take one or two from the discussion. I'll be very happy if one person can maybe get up and say something that they've been able to take away from this discussion. And then we can call it a wrap. And please, there's a CPD for the CPPA members so they can stay after this.
Thank you very much. I think we will have to have last comment from the chairperson, and then we end it. Oh, okay. All right.
My name is Abraham Jesse, registration number 415. I would like to congratulate the current leadership of the Pharmaceutical Society for organizing this year's AGM in this manner. It is probably one of the best I've ever attended, and I really have attended many. It is probably one of the best that I've ever attended, not only in the quality of the programs and also in the quality of the people that have offered to present and to educate the rest of us. Nowadays, in the olden days, we didn't have anything like analytics. I had to decide whether 10 people is important than 5 or not. We didn't have them. So what I'm pleading all of us is this, that those of you who by dint of hard work and training, you have acquired all this knowledge, is there a way the leadership can invite these experts to try to analyze what has taken place and draw up meaningful conclusions to share with most of us, so that all of us can be part of the process of growing up, and to prevent us from entering into rather hasty decisions, sometimes out of enthusiasm or sentiment. So, colleagues, I'm pleading on your behalf, and I'm charging on your behalf the current leadership to invite all these brainy experts that our society has been blessed with, to look at all the information that is coming out of all of these things, to subject them to all your scientific analysis and analytics or whatever it is, and please come out with a document for the first time to the AGM that this is the summary of the outcome of the AGM. Thank you.
Thank you very much. No, abstract comes before. Oh, I think you will still comment.
Yeah, this is very, very quick. Very quick. Colleagues, we are, I say, we're on a journey. We are on a journey. Others have been able to make it at that level. Some others are in the middle of it. Some are also beginning to crawl. But finally, we will all get there. One recommendation I would like to make is that we have talked about all these initiatives, all these fine ideas. One key thing that we can use to be able to lobby is documentation. Documentation. Every single thing that we do, we need to be able to document, both in the community level and in the hospital level. If you document well, there will be a time we will be able to process those things through insurance claims, and we'll get reimbursed for that. The same way with those in the hospital setting. If we document our clinical initiatives, and when Fair Wages Commission comes and they are checking to see what we do, they will be able to see that we are not only dispensing, but we also have some clinical initiatives that we do. It could be renal dosing, it could be antibiotic stewardship, and all the other those verification that we do. We'll be able to prove that we do other things. And then it will not affect our salaries that much. You understand? Because most of the time when they come, that's what they look at. And they go back there and sit and do back and forth and say, well, they are doing just that. Meanwhile, we know that's not what we do. We do more. So therefore, we should be able to document the things that we do very well so that it will speak for us. So it doesn't get reduced to just dispensing. Finally, we have shared ideas. Some of them will take us a little bit of time, but it needs commitment and resilience. And that's the only thing that will take us forward. Thank you very much.
Sorry, Mr. Chairman, please permit me. I know you're the last to speak, but I just wanted to piggyback on what he said. I think, like he said, documentation is very important. Today, we've had several presentations on pharmacy software. I have a pharmacy software. We had an RX info. We have the approved label. These are all things we need to invest in as community pharmacies. We cannot continue to sit down for WHO, USAID, and whoever to give us data. We need to start getting our own data to optimize care. And I am pleading with you as community pharmacists that please, please, please invest in a quality pharmacies management software where you can follow your patient. We talk about fee for service. We talk about MTN. How are you going to document all of this if we continue to do our 2x4 writing in a book where we may not find it next year? Or we're still using some 2019 Kojogo computer. So please, 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 I'm pleading with you. The POS that we are using in our community pharmacies is not enough. If we want to focus on service, please let's invest in pharmacy software management so that we can improve care for our patients. Thank you.
Thank you.
Yeah, so as we move away, let's remember 3 stakeholders: the practitioners, the proprietors, the regulators. Whatever we've discussed there, let's understand that to achieve that success, it's not going to be one person's effort. It's a concerted effort. Thank you very much.
Thank you.
Be better for them. The next on the list is FDA. They have some short presentation to make. So FDA, let's invite them. Oh, it's just a swift one. They will finish very soon. Please, we are not done yet. We are not done yet. I have an important information to give you.
Hello. Good afternoon. I know we've had a very long day, but FDA wants to do a very short presentation. It's actually an acknowledgement of the efforts of the community pharmacists in helping to ensure patient safety. So we have like a few slides, and we have about 5 people we want to recognize and give awards to. So I remember during the panel discussion, Dr. Vera was saying that she vaccinated over 2,000 people and got a certificate. But FDA, we've given the certificates before, and today we want to give the people some things that they can use. So please, give us 10 minutes of your time before the Bo White play. Thank you very much. So shortly, what we call the Patient Safety Centers Initiative. Am I getting help with the slides? The slides, how do we get change? Oh, thank you. So the next slide, please. So we know the Food and Drugs Authority, we regulate the medicines by making sure that we have registered medicine that are safe, efficacious, of good quality. And our responsibility is not just to make the medicines, approve them, and that's it, but to make sure that as long as they're on the market, they are continuing to be safe. So FDA collects adverse drug reaction reports from healthcare professionals, industry, and the other persons. But most people who report the adverse drug reactions are healthcare professionals. And there is a limitation to that because there's a lot of underreporting. So what it means is that, hello, 5 minutes. So from WHO's perspective, you're supposed to have about 200 reports per million population, which you don't have. So FDA has put in place several initiatives to improve reporting of adverse reactions, including CPDs. But one of the things that we did was to brand community pharmacies as patient safety centers. So we started with a pilot with about 9 community pharmacies. And we've been on this journey with Community Pharmacy Practice Association all this while. And at the 2014 AGM, we gave the feedback from the piloting to them, and we showed that community pharmacies will be a good place to collect adverse drug reaction reports. Next slide. So why patient reporting? This is because, as Bob Marley and the Wailers said in 1960, yes, he who feels it best. So patients take the medicine and they have the adverse drug reactions. So in 2016, we launched the Patient Safety Centers Initiative, where community pharmacists who volunteer to be centers for reporting adverse reactions are trained and given tools to help with reporting. So the objective was to enable patient reports their medicines and other health products through community pharmacy, because as it is, point of call and the patients trust us. Now for a pharmacy to become a patient safety center, they must have a pharmacist who is trained, and then to report, and then availability of the reporting forms. Next slide, please. So we had a training that was in 2015 for some people at Mechlin and Kumasi. Next slide. So we in award system to motivate community pharmacists to take part in the program, and so we're giving the certificate. So you see that we have Jogani, that's in Boranga then, and then these are the pharmacists the 2018. So I see all of my colleagues, Kraku, who is there. Then there's also Fabi with us throughout the journey. Next slide, please. And the instituted the CPD program. Get 2 CPD points for reporting at least one adverse drug reaction report. But pharmacists facility that has been designated as a patient safety center. So with that, we got accreditation from Pharmacy Council, and in 2018-2019, we awarded about 50 community pharmacists with 2 CPD points to help with their redesignation. So this pharmacy, Gina Pharmacy, is in the northern region, and in 2019, our drug lens, we published them as the best pharmacy participating in the Patient Safety Center in 2018. Next slide, please. And this is Union Square Pharmacy for 2020. They were awarded for 2019. Next slide. So we have Robert Inkum there. So totally we have about 720 patient safety centers. But unfortunately, we have only about 390 reports since last year, December. Most of the reports are from the northern region. You can see that they have about 35% of the reporting from community pharmacies, followed by Greater Accra, even though Accra has the largest number of community pharmacies. And at the end, we have Upper West region. Next slide, please. So there are challenges and also there are recommendations that we hope to get from you, but because of time constraint, we'll share with you the opportunities and the challenges and hope that you can, with time, give us some of the recommendations to improve the initiative. The opportunity is that it adds value to our service as community pharmacists. If the client knows that it's not just about buying the medicine, but you ask about did they have any adverse reactions, and they know that you have contact with FDA that you can report to them, there will be more services. And also, as pharmacists are going into immunization programs, it will be helpful for them to know that you have a safety at your pharmacy where they can be assured that the vaccines they're receiving there are safe. But the challenging thing is that, as you can see, the reports that we're expecting are not that many. Even though when people come and they may refill their prescription, they might have some adverse reaction or side effect that we do not ask about. So we need to ask them and be able to report all these to the Food and Drugs Authority using either our paper forms of the app. Next slide, please. We would like to say that patients are experts in their own chosen field, namely their own lives. So we must involve them in our work. And pharmacies are the center of all this patient safety center initiative. So we would like to say that we appreciate your time here, but for us to award our colleagues who have been doing well, please give us 5 more minutes and they will mention their names and they are here, so that if somebody is doing an award and nobody is watching, then they feel bad. So please, for the sake of our colleagues. So for the first person, we have Smart Chemist, which is also in the Northern region. So do we have the representative of Smart Chemist here? So if I can indulge our expert committee panel that was here, if Prof. Wuto is still here, yes, thank you very much. If you kindly give the first award to Smart Chemist. So our colleague is bringing the award. So it's a t-shirt like I'm wearing and then a flag. So that's not just a certificate, but they can have some in the pharmacy. So please. So as Smart Chemist receive, we can go to the next pharmacy. Gina Pharma. Thank you. So when they finish, if we can kindly call on Farm, no, I'll call that. Oh, okay. Then we'll call Dr. Vera Santi. Give the award to Gina Pharma. Please clap for Gina Pharma. So while they are there, we let, yeah, thank you very much. We have Royal Avenue Pharmacy, Mr. Ofamyao and Siri. Okay, so please, let's clap for the person. Yeah, Dr. Vera, if you can help us with that one. Then for the next one, we have how do we have Joel? Yeah. He's gone. Joel is right. Joel. Oh, Joel, please, if you can help us. Thank you very much, Dr. Santi. And so, Joel, yeah, Honsal Pharmacy. You are a rep from Honsal. We'll take it to the person. Okay, then Fabi Chemist, please. Fabi Chemist. Okay, please. Somebody should come and collect on behalf of Fabi Chemist because our presenter is already here. Thank you very much for collecting. So, thank you very much for the patience, and then do have a lovely evening at the White Plate. Thank you.
We will have our last abstract from Margaret. Or you're no more doing it. You're okay. All right. Announcement from.
Ladies and gentlemen, the CPPA CPD is no longer coming on. Yes. However, we'll make sure you are given the credits that you deserve. Thank you very much.